Hey folks, Scott Weingart here, and this is an EMCrit Shadowboxing episode. This case was brought to us by the master of the shadows, Shadowboxing editor, Ryan Barnacle. It is a fantastic case. I really like this one. This is the direction we're going. It's cases that are a little bit beyond bread and butter, just a little bit off from what you commonly encounter. So not only will you get the shadowboxing experience, but you will actually learn things that you might not have known before. So this case, wonderful for trainees, but I think all people should listen to this one. Good things in here. And it is a trauma case, which I always love. Now, you know shadowboxing, Gary Klein's idea that the best way to learn is to have a story told to you, a presentation of something in your field, and then have pauses where you are forced to think of what you would do at that exact moment, and then hear from experts or supposed experts about what they would have done, and then you can match what you were thinking with them, and that is one of the best ways to gain tacit knowledge. So throughout this episode, you will hear this creepy shadow sound, and when you hear that, press pause on your cassette deck, CD player, MP3 player, what have you, iPhone, and then think what you would do, and then hit play again, and then hear what we discuss. All right, let's get right into it. Ryan, why don't you ask people to introduce themselves, and then we'll go from there.
Yeah, sure. I'm Ryan Barnacle. I'm one of the attendings on this case in the ED, and I'm the Director of Emergency Critical Care at Brown University.
My name's Cole. I'm one of the EM residents, PGY2 at Brown University.
And my name is Tanuja Subramaniam. I am one of the neurointensivists at Brown University.
And we were all involved with this case at one point or another.
All right, so you all had your fingers in the pot, so I am the only person going in blind. We'll see how that plays out.
Cool.
All right, so Cole, why don't you start us off?
Sounds great.
Get us to the case.
Great. So the case is an elderly man. We were pre-notified of an elderly man who had fallen. It was a witness fall, mechanical in nature, struck his face, no reported LOC, but was pre-notified because not moving lower extremities. And there was this episode of pulselessness in the field where CPR was initiated for one round. No meds were given, and patient then woke up. His lowest blood pressure in the field was 124/56. They had a SpO2 of 70%, but rapidly improved to 98% with a little O2. And given his neurodeficits and this question of CPR, loss of pulses, he was a pre-notification for a level A trauma.
So just for the audience, like when something gets called in that sounds this serious, we get enough time to be ready. And so we were all waiting for this patient.
So this patient rolled through our doors, activated as a level A because he met criteria with the bilateral lower extremity numbness and weakness, and the reported neurodeficits and the loss of pulses. On arrival, he was talking. His vital signs, he has a heart rate of 63, had a respiratory rate of 26, a BP of 102/62, SpO2 of 99% on room air. The wand temperature was 96.5, and he was GCS 15. He was brought into our trauma rooms. His primary survey was intact, no respiratory distress, clear lung sounds, no reported thinner use. The only medical problems that he had was chronic pain. He was on oxycodone. He was ANO times 4. He had an abrasion contusion over I believe the right side of the face. And the patient reported no sensation and was not able to move his bilateral lower extremities. Initially, there was reports that he was moving his upper extremities. I was reviewing the chart and I couldn't really remember exactly if he was moving his hands or his arms, but he was able to shrug his shoulders, and he had a small abrasion to his hand. Otherwise, his secondary exam was pretty unremarkable.
All right, so we'll pause there. So this is a trauma patient with obvious trauma, and it was witnessed by his wife, who reported that it was legitimately just like a trip over something in the kitchen. But we're obviously going to image this patient with essentially a pan scan, but I'm just wondering what Scott's initial thoughts of the pre-hospital reported loss of pulses is all about. Does this fall in the category of a traumatic arrest? Is there more information that you want to know right now, or any more tests you want to do before he leaves the resuscitation bay? Because he seems perfectly stable at this point.
All right, what do you think so far? What do you think about this cardiac arrest? And what would you be doing right now? Yeah, a few things. One, the pulselessness in the field. If he had this incident right after his fall, if he had LOC and then looked like he was in cardiac arrest, I'd question whether it was cardiac arrest at that point. There's a situation called impact apnea where a patient hits their head and just stops breathing, and that's usually what that is. But this patient seemingly didn't have LOC and then had a cardiac arrest. I mean, again, if he had some LOC, woke up, and then succumbed, I'd worry about an epidural hematomia with a lucid interval. But again, that doesn't fit either because he had no LOC. And his immediate recovery from this quote-unquote cardiac arrest also doesn't make sense. So it sounds more like a syncope, right? Like he was okay, he didn't have LOC, he syncopized, and then he came back shortly after that. I'm going to put that aside for now because I think it might be a distractor. Trauma is still a trauma. You do it algorithmically because it keeps you from missing things. Obviously, neurogenic shock at this point is definitely the potential thing we have to think about. And I'd love, before he went to CD, to actually find a sensory level so I know what I'm dealing with. Him shrugging the shoulders means that it's going to be below C5. Does he have an actual sensory level?
Yeah, and so that I would also ask, usually we typically don't perform like an extensive neurologic exam during that initial assessment. Is there more exam findings that you would want in addition to a sensory level, given the paralysis?
Yeah, I think good question. So I'm trying to think about this more from like an ER doctor standpoint that has several critical care patients at a same time, right? I would say maybe a little bit more detail in the motor exam, although I have to say so far you gave a sensory level and you gave a brief motor exam. I think that should be good enough at this point before you call your consultants.
So Cole, what was his sensory level?
So his sensory level was T1 sensory level.
All right. So T1's interesting because in general, people think the sympathetic change is just a cervical issue, but the upper thoracic spine could still be a situation of neurogenic shock. And so that's still potential. And his vital signs somewhat supported. He has a mild bradycardia. He has a borderline, but not profound hypotension. All right, I'd like you to think now about this patient's respiratory situation. Do a mental respiratory assessment and think about, is there anything you should be considering in this patient at this point? And the other thing is, are we getting some accessory muscle hits with this tachypnea? The patient's obviously not going to have a loss of diaphragmatic innervation, but so much of our respiratory mechanics are also from those auxiliary muscles. So this is a patient I'd take a real close look at, and this would only take a few seconds to say, is this a patient safe to not have their airway protected and mechanical ventilation at this stage? Can I get through a CT without doing that? Or is this a patient that I have to manage with a little bit more acuity? And those lower cervical levels are really where I think people get burned because the patient's breathing okay, they're satting okay. And people are like, they're fine. And then they're fine until they're not. And then they just can't cope anymore. And then they kind of crash. And that's not good if you're in like a tube with very little access. Thanuja, what do you think about that?
Yeah, I 100% agree. I was waiting for you to talk about the patient's breathing. So you mentioned the respiratory rate was 26, but how was he breathing? Was he comfortable?
So he looked really comfortable. He was like totally having conversations with us. He was not short of breath. He was on no oxygen, like when I saw him and was interacting with him.
Yeah, I would say that these patients have a high chances of declining, and given the degree of injury in the motor exam that you explained right early on, I would be worried and concerned for a decline down the line, because if there's any sort of spinal cord injury, they may look okay for now, but edema gets worse. If you move them, they can get worse. So you may want to consider, even if they look good at this point, electively intubating these patients.
Yeah, I'd be down for that as well, or at least a strong consideration. And perhaps there's patients we send to CT with no one who could assess and manage the airway. And then there's patients who we say, wow, this is a really borderline situation. I'm going to go over as someone who could actively manage the airway, and I'll be watching them like a hawk. And that's also an option. But the other thing is, you don't want to, if you could avoid it, take away a good exam potential until someone clever is at the bedside. Now, if Thanuja was there, then that's fine. But in most cases, the exam provided by emergency medicine is really not going to be adequate. And it's going to be an arbiter of what our later critical care is. As trauma fellow having to perform an ASIA score on a lot of these patients, it's a real pain in the ass, and there's no way anyone from emergency medicine is ever going to be doing that. If you go into intubate and the patient's stable and you can get neurosurge should just be able to do a quick exam, that's a nice thing to have. The other thing before going to CT is I don't like this patient's blood pressure where it is if I do have such a strong suspicion of spinal injury. And the evidence for a MAP push is not great. But most of us, by consensus, agree it's probably a good idea to at least never let them get hypotensive. And this patient, they're not quite there, but they're certainly in a realm where I'd say maybe they deserve a little bit of vasopressor if I really don't think it's a bleeding issue, just to temporize them before we go to CT. Now, for me, that's norepinephrine. It just makes a lot of sense. For whatever reason, and it's baffling to me, but the trauma surgeons seem to prefer phenylephrine, which just, maybe the poorest of all the choices, because in general, these patients need both vasopressor support, but also a little bit of inotropic and chronotropic support is only beneficial. You could even make an argument that epi is the ideal drug for these patients, but I go for norepi at this stage of the game. Thanuja, am I crazy? Is this what you'd do as well? What's your stance?
Yeah, not crazy at all. So just going back, I guess, a little bit to talking, I suppose we can talk about the circulation aspect. With the breathing, I do agree. The ideal scenario is that you have a neurosurgeon there, do an exam, and then you talk to your neurosurgeon about your suspicion, and then, if appropriate, intubate. It's great if you can get that. We know in reality doesn't always work that way. With regards to circulation, so I think the first thing is, of course, developing a differential to why this patient's hypertensive, right? And the biggest two things in setting up trauma for this patient with the story is, yes, is it hypovolemic shock related to blood loss, or is it neurogenic shock, right, given the neurological exam? Now, there's a couple of things about what you just mentioned about how the patient looks that would suggest to me it's less likely to be hypovolemic shock, the fact that the patient's mandating, and everything else that you described about the exam, it's less likely. And also the mechanism of injury seems pretty unlikely. So if your suspicion is for neurogenic shock, right, I think in terms of choosing how do you intervene on this, I think understanding the pathophysiology behind it will give you maybe a sense on how to approach this, right? The neurogenic shock, the idea is that you're losing your sympathetic outflow, and so you're getting unopposed parasympathetic response on your peripheral vasculature as well as your cardiac functioning. And you can see, with this cardiac function, you can see bradycardia, sometimes decreased inotropy, decreased chronotropy. And then in terms of peripheral vascular resistance, the sympathetics vasodilates your vessels. So because of this range of effects you can get, I agree that I would go for norepi as my first line. But how the neurogenic shock or the shock manifests is going to be different for every patient. So I would tailor which pressor I use based on what the patient is doing. And I would try something. If it doesn't work, then switch it up or add a different pressor. That's my approach to this. I also think that if you look at most guidelines, a lot of them recommend starting off with fluids first, which I think it's not a bad idea to start off fluid first, but I think you should be careful to not over fluid resuscitate these patients, because again, if you think about the pathophysiology and you're quite sure that this is neurogenic shock, you should start process early, and norepinephrine would be my first choice.
Yeah, I love that you mentioned that last point, because I think that was based on old thinking, and trauma folks generally lag behind a little bit on the most recent understanding, because yeah, they're right. If you have a vasodilated venous tank, you could argue, okay, we should fill that up and then they're going to have better venous return. But you could also understand that the vasopressors will shrink down the venous side and change on stress volume to stress volume and accomplish the same thing. So for me, and I think you're in the same place, unless the patient actually is fluid down for some reason, I'm probably going to just fix it by fixing the actual problem, which is Hey folks, we're just going to stop for a second because this is a free episode. I'm giving it to you in its entirety, but it's very rare that we have these full free episodes because EMCrit is a members-only site that still has foam, but if you're enjoying this content, please consider becoming an EMCrit team member. It's inexpensive. You get CME. You could write it off on your taxes, but forget all that. What it's going to do is make you the best possible resuscitation and critical care doctor you could be. You'll have the most cutting edge, up-to-date information, and you will get it in the comfort of your car or on the subway or while running. And you'll never have to think, am I current enough or not? Am I taking the best care of my critically ill patients? All right, let's get back to the show. So dilated, so let's slightly vasoconstrict them back to normal. And obviously, Ryan and Cole, I'm assuming you did all the trauma stuff like a fast exam and et cetera to make sure that there's no other sources of internal bleeding besides the retroperitoneum, which we'll rule out on the CT.
Yeah, so you guys are way ahead of us here. So I will just, a little bit of inside thing. EMS was like very concerned about the episode that they witnessed. They were like, this was profound. He Brady'd down. We could not find a pulse. And like, he went from talking to dead and then back to talking. And they were like very struck by how severe of an episode that was. And so it was like announced in the room, and it was definitely concerning to me and the trauma attending. But then we have this like seemingly perfectly stable patient right in front of us. And so what do we do with that? We discussed the possibility that this was neurogenic shock right up front. And while we were doing all those things like the fast, the x-ray, we got an EKG, the patient remained stone cold sober. So we decided...
Stone cold stable, I assume.
Oh, sorry. So he was also sober, but he was stable hemodynamically. But then I think just given, and we also voiced out loud, is this a medical etiology? Was the report of a mechanical fall wrong? And like he had a cardiac episode that caused him to fall. But I think with the paralysis, it was just really pushing us towards a neurologic shock type picture. But he's passed the 10-minute test, those first 10 minutes.
A lot of stuff there. What are you thinking so far? What's going through your mind? And I'll just make a few didactic points because I want to lock them into your head. When you have a trauma, any source of instability is always, always, always from the trauma until it's proven that it's not. And then if you do have instability from trauma, that's from trauma, it's always bleeding until you prove it's not. So it's always trauma. And then the reason for the instability of the trauma is it's always bleeding. And you have that like as sources 1 through 9 in your head. And then 10 is you start thinking things from the trauma, like neurogenic shock and things like that. And then only number 11 or 12 is to posit a medical cause for instability in a trauma patient, which doesn't mean they don't have that. It just means you rule out all the trauma stuff first, and then you rule out bleeding first before you go down a neurogenic pathway. And then once you've ruled out all the trauma, then you start positing, could this be a medical cause? Now, this doesn't mean you can't concurrently consider both of them. Obviously, you have that rational part of your brain, that system 2, and you could do all of these things, being weighed at the same time. But on a system 1 level, your gut, I want you to train your gut that, yeah, this sounds medical, but I think it could still be trauma. Like the perfect example is you have a patient, they're showing signs of instability after a trauma that you say could be from their heart, and you start thinking, oh, could this all have been a heart attack? Oh, maybe all this trauma stuff is just, superfluous. Maybe it's all just a bad MI, right? And that's why they're unstable. Maybe it's cardiogenic shock. No, you've missed the boat. What you should be thinking is, all right, they had a trauma and there's some instability. It seems related to his heart. This must be blunt cardiac injury. And you consider that way before you'd consider a medical source of MI, which doesn't mean if they don't have a STEMI, you don't start activating the cath lab. It's that you start thinking along the lines too of, okay, well, do they have a pericardial tamponade? Do they have blunt cardiac injury? Which doesn't mean you don't cath them. It means you consider trauma first in any trauma. All right, let's get back in.
Cole, just tell us what your interpretation of the EKG was.
Yeah, so at around 11 minutes, we got the EKG. Appeared to be like sinus rhythm, rate of 62. Had a little bit of long QTC of 541. There was like no ischemic changes. V2 looked like there was a little bit of artifact there, but otherwise no like concerning dysrhythmia, no AV block.
And so at minute 27, he was on the CT table. And then what happened, Cole?
I was not in CT for this part. My trauma colleague was in CT. I was attending to other patients, but patient rolled back into the trauma room and I got report that patient, while on the CT table after being moved, Brady down to 0 or 12 with a heart rate, unclear exactly what it was, got a milligram of atropine, quickly responded to the atropine. It sounds like he also became unconscious briefly, but then quickly woke up to the atropine. And then when I saw him after finding this out, he was back to his baseline that I saw him in before he went to CT. At that time, the blood pressure was 150 over 84. He was put on 4 liters of nasal cannula and then brought back to the trauma room.
All right. So let's pause there. What is happening to this patient? Why does he keep basically arresting? While we're waiting for CT results, what steps are we taking to either mitigate these events or investigate them further?
This is weird to me because the classic neurogenic shock patient, they've just lost their sympathetics, but they haven't had anything overt happen to their system, and you could survive fairly well without sympathetics. You'll be bradycardic, you'll be borderline hypotensive, and the reason it's such a pain in the butt is because we do want to keep that spinal cord perfusion up, but they shouldn't be having these cardiac arrest states, and the ones you're describing sound almost like a real strong vagal episode. Now, obviously they have unopposed vagal tone, but this patient is having such profound episodes of vagal effect that they're actually braiding down to unconsciousness. Thanuja, elucidate, explain to me what the hell's going on here.
Yeah, first thoughts, yes, I agree with you. You can survive you should still have your heart beating with just pairs. But if I had to guess as to why this patient is arresting intermittently or going asystolic intermittently, I would say it's probably because of exaggerated vagal response. And even despite what you just mentioned, Scott, about you should still be able to survive with just parasympathetics, we've definitely seen arrests related to spinal cord injuries, predominantly with like high C-spine injuries. It's a thing that happens, and I've certainly seen it before.
Yeah, but a T1, wow, this one's really
Yes, the T1 part is quite interesting. It does make me wonder, performing a whole spinal exam, like the Asia type spinal exam, is quite long and complicated, and you're trying to do it very quickly in the initial stages. It may just be that it's T1 at some point and there's probably cord edema developing and things are just getting worse and worse. So there may be some inconsistency in the exams, but the patient's behaving more like a C-spine, high C-spine injury at this point based on the physiology of the patient.
Yeah, I'll buy that.
All right. Actually, I forget if it was us or trauma, but given the paralysis, neurosurgery was consulted pretty much right up front, even before the CT scan results had come back. So they were able to see the patient before imaging was fully finalized. Cole, why don't you just tell us what their initial assessment of the patient was?
Before you do that, Ryan, do you want the answer to your question of what we'd do to temporize further events?
Yeah, sure. Yeah.
I would just say if I had the patient on norepi and this was happening, I'd probably add in inotropic dose epi. I don't see any downside to that. Again, it's a very small dose of epinephrine to get the inotropic and chronotropic responses. And I just feel that would be some nice voodoo to stave off further episodes of this. The patient might get a little bit higher on their heart rate, maybe somewhere in the 90s would make me very happy. If they had another one of these vagal episodes, maybe they'd only Brady down to 60 instead of to 0. And so that's probably what I would add in.
Any thoughts on like getting a temporary pacer this early on, or do you think that's too early?
Let's pause on that because I think it's worth discussing, because I think, like Scott said, this is atypical for what most people think of neurogenic shock. But when someone Brady's down to 12 on a monitor, you got to ask yourself, should I be controlling this heart rate more effectively? But
yeah, I think putting the temporary pacing pads on while you're thinking about that question, I think would be a smart way to go.
Perfect. Yeah. So we did do that, right, Cole? They came back from CT on the Zoll.
Yes.
All right. So let's talk about what neurosurgery, because I'm going to ask Thanuja about some of this.
Neurosurgery came down pretty quickly. They saw this T1 sensory level. Patient only able to shrug shoulders. They reported no bulbar cable reflex, priapism, and concern for a question of Asia A spinal cord injury.
So Thanuja, what is the purpose of checking bulbocavernous reflex. And how do we like interpret that as what is it an ominous sign if it's not there? Is checking rectal tone like that the trauma surgeons insist we do on every patient the same thing? And what is the significance of the prior prism that he now is showing? And can you explain the Asia scale in general and what the significance of a grade A is?
Yes. Okay, so three-part question. Maybe let me start with the cavernous reflex. So that reflex, bowel cavernous reflex, I'm going to abbreviate it to BCR. That reflex is a sacral reflex. So in general, there are two sacral reflexes. There's the anal reflex and the BCR reflex. Essentially, these reflexes, you're checking it early on to assess the integrity of the sacral portion of the spinal cord. Okay. So you can either do the BCR reflex or the anal reflex. Okay. Now, the purpose of doing it is to really assist with the ASIA scoring, which is a communication method as to how severe and how complete your spinal cord injury is. Because if you look at the ASIA scoring, essentially how it works is that it's an assessment of whether, so if you have the most severe injury, you're essentially defining it as complete loss of motor and sensory function in the lower sacral segment. So that's the point of doing an assessment like that. Now, personally, I think most people would prefer to do the anal reflex as opposed to the BCR reflex. It's done slightly differently, but it tests similar things. It's just how it's performed. And the ASIA scoring method, the actual examination doesn't actually specify that you need to do the BCR. What they do recommend that you do as part of their scoring system is to test sensation around the perianal region, which is quite different from the BCR. So you do one or the other. And then in terms of the next question you had, I think about priapism. So that's a thing that happens with some patients with spinal cord injury, especially in males. It's supposedly rare, but you definitely hear people giving anecdotal stories about it. So I really do wonder how rare it is. So that's priapism. And I think the third part, your third question was
Just what the significance of a grade.
grade A. Yeah, so grade A, ASIA A, grade A means a complete spinal cord injury. So there's no motor or sensory function. Per the ASIA scoring, it's like at the lower sacral segment. All it tells you is that this is a very severe spinal injury that's complete and it's severe.
So but if we're testing sacral nerve function, that's very low. And so if those are lacking, does that just imply that somewhere above in the spinal cord there's a complete injury and then you use your other exam findings to locate it?
Correct.
Yeah, so with partial sparing, you might have sacral function even though you have a level higher up. Now, Danuja, I'm curious about this because thoughts on this might have changed. But for us, one of the other reasons we do a bulbocavernous is to establish that it's not there at the beginning, and then when spinal shock ends, it returns. And we always looked at that as a real marker point of when we have a chance to get back some function that might have just been initial swelling versus what you get is pretty much what you got after spinal shock is over.
So yes, that is the other function of it, to determine lower motor neuron versus upper motor neuron. Now, that I think the purpose of that is more on the critical care portion when you're starting to prognosticate, you're looking at urinary bowel bladder function. But yes, that is the other reason to do it.
And now, Scott, neurogenic shock and spinal shock are the same thing?
No, totally different. And in fact, if you want to look silly in front of your neuro professional, you'll call neurogenic shock spinal shock. They're two very different things. And I know you're just setting me up for a soapbox issue, so I appreciate it. So neurogenic shock is this hemodynamic consequence we see from lack of sympathetic tone. Spinal shock is a temporary period of spinal cord swelling, and you might actually gain some function in the subsequent 1 to 3 days as that spinal shock abates.
Okay. All right, so I think we all are now suspecting a spinal cord injury. How are we moving this patient around, whether it's to and from CT, whether it's to clean them up, whether it's to do a procedure? What are the things that we need to be cognizant of? And is there like a general checklist for these patients that we need to make sure we're meeting when we suspect a spinal cord injury?
You keep yelling at them to walk because they're being lazy, and obviously that's how you handle it. Yeah, I think it's funny because we, in the EMS world and then to the EM world to some extent, like we're petrified of these patients. And then as critical care gets involved, and if they have real experience with spinal cord injuries, and in fact, many tertiary centers will have a specific unit, a neuro trauma unit at the place I trained at, they seem a little bit more relaxed. And I don't think they're too relaxed, but they are relaxed in that I'm petrified. And when they come to the ED, it's just, oh, let us put on some white gloves before touching these patients. And you can't do critical care that way. So they're cognizant of spinal precautions, and they're going to do everything they can to keep the patient's axes aligned. But they're not scared anymore because they couldn't do their jobs. Now, some form of temporary and then permanent spinal fixation obviously makes everything much easier. I think the answers in the ED are, if you have them available, put them in a better spinal collar if it is a cervical or upper thoracic injury. The crappy white plastic ones, which I think we've moved past in many emergency departments, just really are there as a marker of this could be a problem until it's cleared. It doesn't do anything. The more complicated two-piece collars at least have some chance of it. And obviously you're going to log roll the patient for any turns or what have you, or transfers. Spinal transfer boards are great. And these that don't have them should just buy them, if not for the reason of spinal cord integrity, but simply so that your back doesn't get destroyed on every move from stretcher to bed to stretcher, CT, gurney, what have you. But that's the main stuff that's occurring to me in the emergency department. What about you, Thanuja?
Yeah, I agree. So maintain spinal collar alignment with a C-collar. And in regards to C-collar, if you can use the Philadelphia or Miami J collars, they have been demonstrated to be more effective. And yes, ensuring the second part of it is get them off the backboard, ensuring that you minimize injury while they're laying flat. And I think I also want to emphasize, yes, I do agree. In the past, I think there's a lot of concern, like, wow, we shouldn't touch this patient. We should keep them super rigid. There's a lot of fear on the spine manipulation. But obviously it is important, but you do what you need to do. If you need to intubate a certain way, you intubate this patient, because ABCs are still more important. And now we'll talk about it a little bit down the line. We're a little bit more aggressive now. The recommendations for like stabilization of spine and decompression of spine to do it earlier is more on the forefront now. So I think take that into account when you're approaching these patients.
That's fantastic. The other thing I'll say is if the patient has a non-lumbar injury, they do not have to be laid flat in bed, and that's a really deleterious position. But even in the case of lumbar injuries, you could still get a slight head elevation. And in fact, our precautions were always 30 degrees max head up. So, flat is a death position for any patient. So the spinal cord injury patients don't have to remain flat either.
All right, Cole, let's do the final CT results and then move forward.
So the other thing that neurosurgery asked for was MAP goals over 85. The only low blood pressure we really had was that initial blood pressure when he came in. And then his blood pressures were all very much 130s, 140s, except for that one episode of bradycardia, heart rate of 12, where the blood pressure was 150 right after. So we followed neurosurgery's recs, started patient on norepi at that time to get the MAP goals at 85. So CT results came back at 63 minutes into the case. Impression, no acute injury to the head or face, no acute intracranial abnormalities, no acute abnormalities in the chest, abdomen, and pelvis, and no acute pathology in the cervical, thoracic, or lumbar spine. So
let's
clean
pause here.
CT.
So there's no spinal fracture on CT. Can we still diagnose neurogenic shock? How common is this? And should we still be treating this as neurogenic shock?
So I would make the argument that in adults, what I call squawked, right? So SCORA, right? SCORA is spinal cord injury without radiographic abnormality. And that was really pertaining to x-rays. In our current generation of CT scanners, I don't really think you're going to have a ligamentous injury with a completely stone cold normal CT scan. I just don't think it happens in adults. I don't think it happens in children either, but I wouldn't make as strong a statement of that. But I honestly have never seen a case. So with the current generation of CT scanners, if it was a good scan and it was read by someone who knew what they were doing, I would argue they cannot have spinal column instability in 2025. Now, what's interesting is that doesn't mean the patient could not have a spinal cord injury. So a spinal cord injury without spinal column instability. And so this patient obviously needs an MRI.
Yeah, this is very interesting. Before I address the CT findings, can I talk a little bit about the MAP goals? Because I do think this is quite important. You mentioned that. So interestingly, of all the critical care interventions that's been studied, there's not that many for spinal cord injuries. It's actually like augmentation of MAPs that have been shown to be having to have some sort of improvement. And in the past, the recommendation has been pretty high in terms of what MAP goals. I believe it was like above 85, around the 90 region. The most recent guidelines actually recommend 75 to 80 as their lower goal and 90 to 95 as the upper limit. That's the 2024 guidelines. I will say it is probably one of the most important critical care intervention we have, because MAP augmentation is really the only thing you have right now to improve spinal cord perfusion while you're waiting for perhaps more definitive treatment if indicated in the OR. So that addresses the sort of MAP goal that's recommended by neurosurgery. And then with regards to the spine imaging, so yeah, Scott, you're right. It's really rare, especially in adults. It does occur in pediatrics for various reasons related to the anatomy, but it's quite rare. However, ligamentous injury aside, there are things that you may not visualize on the CT scan. That is, if there's like ischemic insult to the spinal cord, depending on the mechanism of injury. Hemorrhage, I would say if the hemorrhage is large enough, you should really see some form of it in the CT scan, but you could theoretically miss it. So there are certain things that you may not see on the CT scan. It is odd that a patient that's presenting like this, that seems at this point pretty clear cut, like spinal cord injury, possibly low spine injury, doesn't have any findings on the CT scan.
Yeah, we were pretty puzzled, and I was panicking about what else could I be missing, but ultimately neurosurgery thought that this was going to be a compressive hematoma that was not clearly visible on CT, and the initial plan was to get an MRI, but Cole, you can talk about what happened next.
For sure. So I called MRI. Patient was next up to get MRI'd. But I also had called cardiology to come down as well too, with these two episodes of this like profound bradycardia that has occurred. So far, patient still was like in the 50s, even on the norepi. They came down.
All right, what do you think cardiology is recommending when they come down?
And they recommended a TVP on this patient because a couple things here. Neurosurgery did not want to wait for the MRI. They wanted to take the patient emergently up to the OR and decompress the spine. And cardiology was concerned that given that this patient has had two bradycardic episodes requiring augmentation and medication, that this patient might need to be paced during this long procedure, and that this patient is going to be on their stomach. And if the pacing pads aren't on there, if there's any complication with the pacing pads, their recommendation was to place a TVP in the ED and then bring the patient up to the OR. So that is what happened. Neurosurgery was at bedside. We placed the TVP and they took the patient right up to the OR.
First of all, I commend your institution's neurosurgeons, because that level of aggressiveness is what there should be out there, but very rarely do I see that. So that's fantastic. The TVP, obviously, yeah, makes sense. Why not? Just don't turn the patient's head when you place the IJ line and you'll be fine. So very cool.
Yeah, so I had gone home before the TVP.
That's not how I trained you, but okay.
Came up. And so like when I was like, wow, I never really think about a pacer in the management of neurogenic shock. But then when the logistics of going to the operating room came into play based on the other episodes, I was like, yeah, that's a good move to have. Because we were able to reach a MAP goal easily, but he was bradycardic to the 40s and 50s. We wanted to stave off any further episodes. So I guess TVP was the move.
So what they find in the operating room?
They did a laminectomy C2 to C7, arthrodesis C2 to C3, and then posterior cervical C3, C4, C5, all the way to T1, T2 arthrodesis, and then a posterior segmental C2 to T2 instrumentation.
It was a hematoma.
Oh, there you go.
So that all is that's fine. The real question of whether I should be reassured or petrified from this case is, did the patient actually have an unstable spinal injury? Because if they managed to generate a hematoma without a bony instability, then all of my paradigms continue to be maintained, that I could clear a cervical collar off a patient based on a pristinely negative CT scan. On the other hand, if they tell me there was a grossly unstable bony injury, then that's really scary. And so, but we don't have that answer is what I'm hearing.
Yeah, but I guess with a normal CT, but the persistent neurodeficits, you wouldn't clear a C-spine.
Again, we're not talking about the patient we have a high index of suspicion on. We're talking about the patient who's unconscious, who we do clear the collar on, because that's what the current thinking in neurotrauma is, that even if they had a hematoma and we then discovered that they had an actual level and had to intervene on, that's fine, because the movement in between, the patient didn't have bony instability. You see what I'm saying? It's the difference between hematoma with a patient who you could piff by turning their head versus a hematoma in a patient who, if you move them around, it doesn't matter. Their bony stability was intact. And what we've been teaching and what the current state of play is that you can clear unconscious patients based on a CT scan, that MRIs are now superfluous. And so the question would be whether this case is a argument against that, or it's fine. The patient had a hematoma. It makes complete sense. They had all of these actual neurologic issues, but did not have bony instability.
Yeah.
That's a really good point.
This is why it was a tricky case.
No, it's a great case. I love it.
Yeah.
So much good fodder here. Ryan, is there anything we haven't hit that we should?
I think we can probably summarize the hospital course. It was brief, and then go from there. But close it up. Cole, you want to just walk us through the next couple days?
Yeah. So uncomplicated surgery on hospital day 0 into day 1, placed on the bear hugger for some hypothermia. MAP goals 85 for 7 days. The TVP was removed on day 3. And then MAP goals were adjusted to 65. It looks like on day 4. On day 5, his, I believe, his left lung got like full of fluid, collapsed. CTP was negative. Looked like he possibly had a pretty large pneumonia, started on Bactrim at that time. Family was okay with a trach and peg plan. And then what ended up happening is they found his living will, brought that in, which sort of said, I don't want anything like that, no trach, no peg. And so he had a terminal extubation on hospital day 9.
Did he actually terminate? These patients usually can make it through at that spinal cord level, especially after a decompression and removal of hematoma. Did he succumb from his extubation?
Yeah.
That's interesting. It does support Thanuja's and my point that intubation is pretty key on a patient like this, and because they do eventually crash. My imagining is that the pneumonia was also as a result of a patient lying flat who probably was in respiratory compromise that just wasn't reflected by saturations. It's another argument for early intubation. What wasn't done and shouldn't be done, but it's worth mentioning just as a public service, because I still see trauma surgeons asking for this, is there's no indication for steroids in these patients. And
I meant to bring that up.
Yeah,
the patient did get steroids, at least up front.
God.
I don't think through the ICU stay, but up front got Decadron.
Look, the Decadron dosing you used, I'm sure, was fine and completely irrelevant, because the real problems come from insane doses of methylprednisolone. So if you gave the patient 10 of Decadron, it's completely useless, but I'm sure it didn't do any huge harm. But the doses that are actually indicated for spinal cord injury when it was still done are deleterious and been proven negative by a good body of evidence. So that should not be done anymore. I'm curious about induced hypothermia, Thanuja. They were keeping this patient not febrile, which makes complete sense. There's been banding around of whether these patients should be cooled or not. What are you thinking on this?
Oh, I'm not sure that there's been very much studies with regards to that. There's been interesting work about how neurons behave when they're cooled. So I think that maybe if people run better studies, you could maybe see a positive outcome with that. Personally, I haven't had any experience with that. Have you?
No, I think it's always put out there as a consideration, but until there's evidence, I think it's a pain in the ass to actually do until it's proven. So I'm gonna hold off.
But actually, before we wrap up, let's say we did intubate this patient. Is there any like specific things technique-wise that we should keep in mind when intubating a patient with suspected, like highly suspected, especially cervical spine injury?
Yeah. So classically, this would have been an awake intubation. I shouldn't say that. Truly classically, like 1970s, 1980s, these patients all would have received a cricothyrotomy empirically because they believed that any degree of entry through the mouth or nose was contraindicated. And that's where you could have gotten a lot of experience doing cricothyrotomy. But unfortunately, about 40 to 50% of them went horribly wrong. So that was quickly disappeared as a move. And then they started doing, in the elective intubations, not the crash ones, video or fiber optic intubation. They felt that was the least spinal cord movement. But current thinking is, and I agree with everything that's being said currently, is do whatever you're best at for the elective intubations. And if that means you have only picked up a bronchoscope for an intubation once in your career, don't do that. Now that we have video devices, the spinal cord movement for either hyperangulated or standard geometry with bougie is shown to be minimal. And whatever you do that involves the mouth is really where the spinal cord injury is going to result. Just be delicate. It should be an experienced intubator, but whatever you're best at. So if you take someone from the MICU, in general, they really feel comfortable grabbing a video bronchoscope. Okay, great. Topicalize that patient, do it video bronch. If you feel comfortable doing an awake with a video laryngoscope, do that. If you only feel comfortable doing RSI, that's fine too. Just make sure you don't drop the blood pressure. So don't use agents that are going to cause hypotension. So I don't think it's a great propofol case. I would use ketamine. That's going to either augment or maintain the blood pressure and heart rate. And I think you'd be fine. What else could we say about the intubation?
I would say, so just there was from anesthesia, there was in the Difficult Airway Society in 2024, they did come out very strongly about some guidelines for C-spine injury airway management, and they come down pretty much saying VL or bronchoscope, video bronchoscope should be used. Like we should really
exactly
be DL.
Right. Exactly right. Yeah, no, I think I said that, but I'll reiterate it if I didn't. Never use DL, but don't use DL here especially. Now, Thanuja's point that she made earlier was fantastic, which is the risk of this patient is far more from a degree of hypoxemia from an intubation you can't get because of strict inline stabilization than the slight movement of letting up on that a little bit and getting the tube in. I love inline stabilization for this, and it should be done properly, meaning you're holding your hands over the patient's ears like your earmuffs, not over the patient's jaw, which actually prevents the patient from being intubated. Because since there's no capability of you lifting the head, the only way is displacement of the mandible. So if they're holding the mandible, you're screwed. But if you're not getting it, don't abandon that and try to bag these patients. Just say, give me a little bit of play here. And that might be the difference of getting that tube or not, because the risk of hypoxemia is far greater than the risk of slight movement of the spinal cord from inline stabilization, relaxation. Thanuja, what do you have to add to this?
Nothing other than do what you're comfortable with. Use technology to minimize movement.
There you go.
And secure the airway as fast as you can.
Fantastic.
That's all we got.
All right. That was a great case. I love that one. Thank you all. This was super fun. And we kept it under an hour, which is our real goal here. Good job all around. All right.
Yes.
Awesome.
Yeah. All right. Lovely. Thank you all.
All right, let's do it again soon. Thanks, everyone.
One additional thing we learned later, and really I think influenced neurosurgery's aggressiveness, is this patient seemed to have been getting worse from the descriptions in the field where he was moving his hands to the point he could only shrug his shoulders in the ED. And then actually during neurosurgeon's evaluation, he actually lost his shoulder shrug. And that really convinced them that this was a hematoma that was actively advancing up the spinal cord. And they're like, no MRI, we're just going right to the OR, which is fantastic. So many good learning points in this case. You can indeed still have spinal cord injury even with the bony stability of the spinal cord. So patients with neurodeficits still need aggressive evaluation, whether it's MRI or direct look in the operating room. You can actually have cardiac arrest from the increased vagal tone of neurogenic shock. So be wary of that. And these patients may need counter to that, things like transvenous pacing, etc. Airway management should be early, even in patients who seem to be doing okay at the moment if they have a low cervical and sometimes even high thoracic. And let's be real here, this patient probably had an advancing cervical injury based on their exam progression. Be very wary of just thinking those patients are okay. They crash at the worst moments. Your airway management should be whatever you're best at with minimal movement of the spinal cord, but that doesn't have to mean a video bronchoscope awake. It could mean using VL and whatever you're best at. And RSI is just fine if that is what you are skilled at. Just don't drop the blood pressure. All right, so many learning points, so much good stuff. You will hear from us again next time.